Good morning. Thank you very much for being with us this morning. I'm Dr. Osama Gaber. I'm the director of the Houston Methodist J.C. Walter Jr. Transplant Center. We are in unprecedented times. This new pandemic has really forced us all to change so much in our life. And we thought that as a service to all of our transplant staff, referring physicians, and probably our transplant patients and the public in general, that we could put together a educational seminar on the COVID-19 in transplant patients. This morning, I want to thank, before I start, the Methodist DeBakey Heart and Vascular Center for offering us their amazing studios to broadcast this educational conference and webinar. And I think it's been a tremendous asset for the whole institution to have this and for us to be able to use it to reach our patients and our staff in these difficult times. We have a panel of 4 speakers, and we're going to be taking questions from anyone who is attending. You can text your questions to DeBakey 37607, or you can write your questions online to polleverywhere, pollev.com/DeBakey. We are going to try to get to as many questions as we can. I want to take you first through a very quick introduction as to the where we are with the COVID-19 virus. Most of you know this by now, but the SARS-CoV-2 is the virus itself. It has an interesting journey of how it made it to man. But we know through the genetic analysis of the virus itself that it has 96% homology with another SARS-CoV virus that has inhabited bats for a very long period of time. A small amount of the genetic code that's present in the virus that infects humans actually comes from an exotic mammal that's found in Malaysia called the pangolin, which I hope you can see on the slide. The pangolin is actually one of the most endangered mammals because it's been continuously poached for its scales and meat, and it's sold as a sort of a delicacy in many of the far eastern, of the southeastern countries and in China. And we think that the epidemic started in one of those wet markets in China in the city of Hunan. And as you can see, or you know, that from January till about the middle of February or the beginning of March, that whole province was put on lockdown and actually resulted in controlling the spread of the virus in China. Unfortunately, because of international travel, the virus spread has now made it all over the world and has become a pandemic every place in the world, with the United States now having more cases than actually had been reported in China. The outbreak of the virus, the transplant professionals and transplant patients need to understand that we have a lot of outbreaks of other infectious viruses. Like everybody says, this is like the influenza. The difference is we do have some herd immunity, that is immunity that has been acquired through exposure previously to some of these viruses. So even when you get an outbreak, then eventually the people who have immunity stop the spread of the virus. However, with the SARS-CoV-2 virus, we don't have any herd immunity. So the spread is, as you see on the slide, is exponential. It goes, one person can infect many people, and it keeps going on. The problem is that even with a small percent of the patient developing serious disease, that you run the risk of overrunning your healthcare system by the number of patients that are hospitalized and needing critical care and intensive care. And the idea is that if we can limit the spread of the disease by limiting social interactions through the distancing, then I think we can go from that red curve where you have this very phenomenal expansion of the number of cases to the grayish curve at the bottom where we actually do not exceed the capacity of the people. That's why putting together social distancing guidelines has been very important for the community to prevent the spread of the virus. One person, if left unrestricted, can possibly in 5 days infect about 2.5 people. And you can see that in 30 days, that would lead to infection of close to 400 people. But once we started putting restrictions, we have decreased the number of patients that can be infected. And at 75% less exposure, one person in 30 days would only infect 2.5 people. So it's a huge difference in the number of infections. That's why we're calling on everybody in the country, basically, to stay in place, try to avoid social interaction so we can limit the virus. And you can see, if you look at it, this is what happens when one person who worked from home and one person who didn't go to a barbecue result in the decrease of the number of cases that is seen over about a 4-week period of time. It's a huge difference. So again, we cannot overemphasize really staying where you are and not getting exposed to other people. There are two concepts that I want to explain because everybody talks about the high fatality rate. There is a difference between the case fatality rate and the infection fatality rate. So we know, for example, that of 30 people that are infected, if hypothetically only 10 we do diagnose the virus in, and 1 dies from the 10, then we would say that the case fatality rate is 10%. But if we have 20 undetected instances, so the total for the the infection fatality rate is 1 out of 30. That's only a 3%. And this is, when you see these numbers, you just need to understand the difference between the case fatality and the infection fatality. COVID-19 is the disease, and I think Dr. Knight is going to speak about that a little bit more. But the symptoms, the 3 most important symptoms, are fever, dry cough, and fatigue. These occur in somewhere between 87% of people will have fever, while about maybe 35% will have fatigue. Lesser symptoms include sputum production, shortness of breath, joint aches, and sore throat. Everything after that occurs in much lesser frequency. And I'm not going to go into this, but basically, if you take a comparison between COVID-19 infections, the common cold, the flu, and allergies, fever is very common in COVID-19. It's rare in the common cold. It's common with the flu. Sometimes occurs with allergies. Dry cough, which is very common with COVID-19, is mild in the common cold, is common with the flu, and is sometimes occurs with allergies. And shortness of breath is really almost pathognomonic for the COVID-19, although with allergies you can get some shortness of breath if you have a severe episode. So basically your physician is going to be able to tell you, based on the symptomatology, if you're at high risk or not because of the symptoms, and then direct you to some testing. This is the national map of the spread. We all know that New York, Washington, New Jersey have been sort of, Connecticut have been the focus of the current infection, but we're starting to see some other areas like in Los Angeles and maybe New Orleans where we're having infections that are rapidly increasing. In Texas, you can see that Houston and Dallas seem to be, because of the major urban areas, where we're having most of the infection, but luckily up till now, we're still able to not hit that very exponential growth phase, and we're hoping that we can avoid that because of the earlier placement of the restrictions on travel and gathering and so forth in our area. So finally, I want to say that I want to give you an update for our patients and for our staff. We are seeing a steady rise in the number of patients in the hospital. We have in our whole system, which is 7 hospitals, we're approaching about 100 patients. But there have been only 3 transplant patients that have been confirmed COVID-19 patients. 2 of them have recovered well. Both of them are kidney recipients. And 1 is making a slower recovery and is still hospitalized as a lung transplant recipients. I think we're very lucky that up till now, our patients have been safe, and I think that's because our patients know to be careful and to practice all the good things we ask them to do, which is hand hygiene and social distancing and so forth. We've converted most of our care into virtual care at this time, and we've carefully evaluating every transplant for risk-benefit ratio. So if somebody's transplant can wait without, where the risk of an infection or coming to the hospital is higher than the benefit that they're going to get from an urgent transplant, we've been putting those off until such time where that risk-benefit ratio tips towards having the transplant. Personal protection is key. We have to have excellent hand hygiene. I know the transplant patients, they hear us say that to them every time we discharge them from the hospital. We have to cover our cough, do social distancing, clean surfaces, mostly with bleach or alcohol. And if you feel bad, start self-isolation and call your doctor. Masks are, standard surgical masks are good for droplet protection if you're not feeling well. We're now seeing the government trying to say that maybe they will advise that everybody wear a mask. That hasn't happened yet. But up till now, we just think that the best thing is just social distancing and hand hygiene. So this is my introduction. I want to tell you that at the front lines of this epidemic, this is really a war that this country is ongoing with the virus. You can see that our first responders, our nurses, then our doctors and our scientists are trying to find a solution for this. And I'm sure that we all are supporting the efforts that are being done now to contain the virus and to treat it. I want to thank you so much for listening to this. I know that there are going to be a lot of questions. And again, I would say, if you have questions, you can text DeBakey at 37607 or online at polleverywhere, pollev.com/DeBakey. I want to now start with my first guest, Dr. Jason Knight. Dr. Jason Knight is one of those frontline physicians. He is an emergency physician. He's a chief medical officer of the Houston Methodist Woodlands, one of our hospitals in the system. And he is the director of the emergency room over there. So he has a firsthand experience with the epidemic and the virus. And Jason, welcome. And thank you very much for being here. And I'd like you to give our patients and our staff an update about COVID-19 as you see it from the front lines.
Thank you very much for the kind introduction, Dr. Gaber. For the next several minutes, we're going to talk about the technical medical aspects of the virus. So SARS-CoV-2 is the virus, COVID-19 is the disease. COVID-19 is part of a family of coronaviruses. In any given year, there are 4 coronaviruses that are widely distributed among daycares and primary schools and secondary schools in our community. One of the reasons that we don't feel like children under the age of 14, some people say children under 9, are getting hit hard by COVID-19 is primarily because of implied immunity or herd immunity to these other 4 coronaviruses that these young children are frequently exposed to. SARS and MERS previously caused epidemics with a relatively high mortality rate. It doesn't seem like the mortality rate of COVID-19 is anywhere near the mortality rate of SARS and MERS, although much more people are getting the disease, and there's quite a few more infections. So SARS-CoV-2 is the virus that actually binds your angiotensin converting enzyme, your ACE2 receptor, and those receptors are located in your lung and in your GI tract, which is why some people with COVID-19 develop pulmonary symptoms and GI symptoms. COVID-19 right now is mutating, although it is relatively slow. There's 2 stages of this infection. There's the initial viral replication phase, and then there's the body's immune response to the virus. The typical complications from COVID-19 are ARDS and viral pneumonia. The virus is transmitted by large droplet transmission. Originally, it was thought that this is airborne, and this is largely thought to not be the case. So it is droplet precaution, although the virus can stay aerosolized in some droplets up to 3 hours if there's no air circulation at all in the room and the room is closed off, like the WHO study. Just to let you know, that is not the case in our Houston Methodist hospitals. For example, the entire air in a typical ICU room is turned over every 3 minutes. Our operating room air is turned over very frequently, and even our regular normal floor patient care rooms, the entire volume of air in the room is turned over at least 6 times an hour. The virus can survive on the surface for hours to up to a week. Cardboard's thought to be about 12 hours. Plastic and glass and granite are a little bit longer. This virus is incredibly wimpy. Just about every disinfectant kills this virus. So 70% alcohol kills the virus, 0.1% bleach kills the virus. You don't have to pour raw bleach on all of your surfaces in order to kill this virus. 0.1% dilution is fine. Betadine kills the virus, hydrogen peroxide kills the virus, and the envelope of the virus is lipophilic, meaning that soap is incredibly effective. So honestly, washing your hands in soap and water is one of the best ways that you can decontaminate from this virus. Most healthcare transmissions in this country are thought to be due to donning and doffing errors, meaning specifically taking off your protective gear and then accidentally touching your face. Believe it or not, one of the most important aspects to wearing a mask is preventing your hands from touching your face, not so much to prevent all of these droplets in the air from being inhaled. So the whole point of wearing a mask is not to touch your face. There's a concept called rho in epidemiology. If your rho is less than 1, the epidemic tends to burn out quickly. If your rho is equal to 1, the epidemic continues at a steady state. If your rho is greater than 1, the epidemic increases exponentially. And the rho with COVID-19 and SARS-CoV-1 or CoV-2 is thought to be between 2.5 and 2.9. This is an updated slide as of the 31st from the CDC website showing 163,539 cases in the United States. The total documented deaths right now are 2,860, and this is a map of the cases by state. This is the Johns Hopkins website, which reports slightly different data compared to the CDC. But basically the difference between the numbers on these slides is one due to timing. As you can see, there's 883,225 confirmed cases worldwide. The United States has the most confirmed cases, but we are also doing the most testing right now. Italy and Spain and China are also countries with a large number of infections. The total deaths from COVID-19 is 44,156. Italy leads the world in the numbers of deaths, followed by Spain and France. What I don't think gets enough attention in the media right now is that 185,377 people have fully recovered from this disease. The mortality rate if you're above the age of 80 is running around 18%. If you're aged between 70 and 79, the mortality rate's about 10%, and then the mortality rate continues to decrease as you get younger. And as you can see in this graph, if you're younger than 14, your chance of having mortality or any type of bad outcome is exceptionally low. So signs and symptoms, about 88% of people will have fever that have COVID-2. Now, if you look up on this graph on a bunch of the different published studies, you'll notice a bunch of different numbers. The reasons the numbers are all over the map is the technical difficulties and differences in how they assay the patients. So if someone asks, have you ever had a fever or felt like you had a fever over 2 weeks? That's very different than asking someone or asking the question, do you have a fever when you come to the hospital in the emergency department? Quite a few patients have myalgias. You can also see headaches. If you have a runny nose, most people with COVID-19 do not have a runny nose. Chest tightness, dry cough is very common. Hemoptysis is very uncommon. And about 5 to 10% of people, depending on the study, will have GI symptoms. Let's talk about the typical course of the disease. So the incubation period where the virus is replicating is about 4 days. So you're going to have no symptoms for the first 4 days after exposure. If you go back to the glory days of high school and college when your statistics courses, the interquartile range is about 2 to 7 days. That being said, there is a long tail. There's very, very few people that will first develop symptoms about 14 days. But if you've been exposed and you haven't had any symptoms up to 7 days, you're probably not going to develop symptoms from that exposure. If you are going to get short of breath, that typically occurs about 6 days post-exposure. Hospital admission occurs about 8 days post-exposure. And ICU admission or intubation is about 10 days post-exposure, although that course is highly variable and it depends on your age and comorbid conditions. Let's talk about laboratory studies right now. Most people with COVID-2 will have or COVID-19, SARS-CoV-2, will have a normal CBC. there will be lymphopenia in about 80% of patients. If you have low platelets, that tends to be a poor prognostic sign. Most people have normal coags, and an elevated D-dimer is a common sign. If you have a markedly elevated D-dimer, that's also a poor prognostic sign. COVID-19 does not appear to increase your procalcitonin level, so if you have a procalcitonin level that's elevated, you need to look for other causes of infection. COVID-19 does increase your C-reactive protein. So what are we doing at Houston Methodist? We're sending an influenza A and influenza B test. We're then sending a respiratory pathogen panel and the COVID-19 test. It looks like the co-infection rate, meaning you have rhinovirus and COVID-19 or influenza and COVID-19, is somewhere around 2 to 5%. There are some outlier studies, like one that came out of Stanford that said it could be up to 25%. But that being said, most of the data we're seeing on the front lines is the co-infection rate's about 2 to 5%. The respiratory pathogen panel does test for 4 coronaviruses, but it does not test for COVID-19. That is a separate test. Houston Methodist has developed our own test, which is excellent. The sensitivity of the test is running about 75%. The range of the PCR tests in the country are about 66% to 80%. There is an epic order in our system. You want to send 2 nasopharyngeal swabs. 1 nasopharyngeal swab is for the COVID-19 test. The other is for the respiratory pathogen panel. We're also asking people to send legitimate sputum if you can get it, but please don't induce sputum on any patients due to the risk of infection to the staff. If you do send a sputum, the sensitivity is somewhere between 90 and 93%. One of the issues that everybody in the country is having is the issue of suboptimal tests. So I like to make the joke that you have to tickle somebody's brain with that swab. You have to be very, very aggressive with the swab and get the swab all the way in the back of the nose. If someone's not pulling their head back or actually tearing up during the test or saying it's very uncomfortable, you're not doing the test correctly. And there is an online video that Houston Methodist has published showing you how to do the tests. Outpatient testing is available now if you don't need to be admitted to the hospital and need hospital-based services. There also is a consortium that's working at Baker Stadium, and there's a lot of different outpatient testing centers that have opened up. Let's talk about imaging of patients. Many of these patients will need a chest x-ray or a CT scan. Please, please, please mask all of your patients that you are sending for imaging. The reason is because if a patient has a mask, we can decontaminate the room anywhere between 5 and 15 minutes. If a COVID-19 patient comes in and does not have a mask, then it basically takes us between 2 and 2.5 hours to decontaminate that CT scanner. All COVID findings on imaging tend to be non-specific. Usually you start off by seeing a peripheral and basal patchy ground glass infiltrate. That tends to consolidate into viral pneumonia, and then you get ARDS. Pleural effusions tend to be uncommon, and you also don't tend to see lymphadenopathy cavitations or masses. The sensitivity of a chest x-ray is about 59%, and the sensitivity of a CT is about 86%. We are not doing initial screening of all patients for COVID-19 with the CT. Patients who are short of breath are the ones that will probably benefit from the CT. These are some imaging findings of patients with COVID-19. On the top, you see people with relatively mild disease where you see that bilateral ground glass patchy opacities. If you look on the bottom, those are people with much more severe disease. So we know how to treat viral pneumonia and ARDS. We've been doing this for years, and we are really, really good at it. COVID ARDS is a little bit different than standard ARDS. So with typical ARDS, you get problems with lung compliance. With COVID-19, you literally get drowning of the alveoli and fluid and atelectasis. There's been a lot of studies that shown that prone ventilation really helps, and so we're turning patients every 4 hours. We also have a fairly low threshold to intubate and go straight from 100% oxygen to intubation. We strongly discourage BiPAP, high-flow nasal cannula, and using nebs because it basically prevents tremendous risk to our staff. So we're using MDIs instead with spacers, and if you do 1 puff a minute for 10 minutes or between 2 and 8 puffs over the course of 20 minutes, that typically equals about 1 neb. If somebody is intubated, high PEEPs seem to be helpful, so don't just start people at 5. And in some places in the country, they are splitting ventilators in cases of severe escalation and a shortage of resources. There are 69 clinical trials and counting going up every day of drug treatment in the United States and around the world. One of the biggest and most promising drugs is remdesivir. We have that here for compassionate use only at Houston Methodist. We have had patients that have used it. And one of our first patients recently came off the ventilator who did get remdesivir and is doing well. Kaletra, ribavirin, chloroquine, Tamiflu, all of those have been tried and are in clinical trials to a certain extent. The Tamiflu data, Tamiflu does not work for COVID-19. After President Trump came out and announced that chloroquine was FDA approved, that is true. Chloroquine is FDA approved for malaria. It is not FDA approved for COVID-19. I also want to remind everybody that if you're going out hoarding chloroquine, please be exceptionally careful with that drug because literally 1 to 2 tablets can kill a toddler. So please, please be safe with those drugs. Steroids should generally not be used. A lot of transplant patients are on and off steroids. In general, for the majority of the population, steroids should not be used, but transplants is its own separate category, and I'm going to have additional experts speak on that. Antibiotics do not work. There's a lot of data about using interleukin-6, which is a monoclonal antibody, to blunt the body's immune response and the cytokine response. That's especially being used in Italy with good results. IV fluid seems to make the ARDS and people's conditions worse with COVID-19. In general, we don't have any definitive good data with randomized controlled trials right now to recommend one treatment over the other. Most of the studies, even azithromycin and hydroxychloroquine and chloroquine, are very small. There's 6 patients, 25 patients, 20 patients. We need much bigger, better trials, and those are currently ongoing. 80% of people do not get significantly ill and do not require hospitalization. Most of these people are asymptomatic or just have kind of minor cold symptoms, fever, cough, shortness of breath. We do have a Methodist virtual care app that we strongly encourage everyone to use, especially if they are symptomatic but don't need hospital-based services. If a patient is hospitalized, about 10 to 20% require ICU level care, 3 to 10% require intubation, and about 2 to 5% of people who are hospitalized die, meaning most people do successfully come off the ventilator. Risk factors for a poor outcome include advanced age, coronary disease, hypertension, diabetes, COPD, and a variety of other comorbid conditions. We have a number of different donning and doffing PPE recommendations that are posted throughout the hospital, and all of our frontline staff are encouraged to watch the videos and get trained to keep themselves safe. The primary barrier to person spread is excellent hygiene, and please don't touch your face with your hands. Droplet precautions are recommended. N95s are only recommended if you are going to do bronchoscopies, intubations, tracheostomies, very high-risk procedures like TEEs where there's a high probability of you aerosolizing the virus. We also have PAPRs, which are kind of technically or non-technically referred to as the spacesuits in our emergency departments, our ICUs, and in our anesthesia suites. Our visitor policy, we're screening everyone at the door. We're screening all visitors for URI complaints. No visitors are allowed for possible COVID patients unless it's absolutely necessary for medical decision-making and patient safety. Let me give you an example. If a 40-year-old healthy male came in with COVID, they are not allowed to have any visitors at all. If an 88-year-old female came in from a nursing home with severe dementia and needs a family member in order to appropriately make decisions, then that family member is allowed, and we do provide that family member with PPE. But in general, we are limiting all visitors and no visitors under the age of 18. So kids right now, as we talked about, are not really getting infected, but it's unclear if they are actually transmitting the virus throughout our community at this point. Here's some information about our Houston Methodist virtual urgent care that you can all access online. There is a national shortage of blood right now due to an over 25% reduction in people donating blood. So please, please use blood judiciously. We have canceled all elective surgeries in the Houston Methodist system. We're not doing any facelifts or bunionectomies or elective surgeries. We're trying to put off all non-emergent surgeries as long as possible. We are still performing any urgent or emergent surgeries. Many people have asked me how long, based on my frontline experience, that I think this is going to last. My best guess at this point is that we're probably going to have a peak number of cases at the end of April or early May, but it all depends on how successful we are at flattening and bending the curve. Social distancing is helping tremendously, and I think that at a minimum, we're probably going to extend out into June at this point. As you can see from this graph, the United States has 188,530 cases, and it's still continuing to rise. We need to bend that curve and bend it very quickly in this country, as China, South Korea, and Singapore have done. Thank you very much. Please text in your questions, and with that, I am going to turn it back to Dr. Gaber.
Well, thank you so much, Jason, for such a great presentation. I think the presentation gives us an amazing amount of information that is very helpful for our patients and our healthcare professionals. I do have a question from a liver transplant recipient. He says, I'm a liver transplant recipient, I'm doing well now. And the question that he has is, besides the general recommendations that we make for people, social distancing, washing your hands, and so forth, is there anything additional that a transplant recipient can do?
So that's an excellent question, and I'm going to give you a bunch of different community kind of based recommendations. So first of all, social isolating is excellent. You need to be at least 6 feet from other people. The reason we chose 6 feet is when you cough, the droplets from a cough that are projected outward don't go farther than 6 feet. So having 6 feet of distancing is excellent. I would encourage you to wear a mask. Wearing a mask reminds you not to touch your face. Practicing excellent hand hygiene at home is really important. I think that if you are living with a number of different people, try to make sure that you clean your surfaces around your house. And I would encourage you to not just clean down the counters and clean the kitchen and clean the bathrooms like you normally do, but make sure that you're washing your seats, make sure you're washing your towels. I would clean the remote control, I would clean your cell phone. A lot of the people's cell phones are some of the dirtiest things they have in their houses. And then in general, I would make sure that you do all the things that we, as physicians, encourage everyone else to do, but people tend not to, which is make sure you get a lot of sleep, don't watch TV before bed, make sure you eat a healthy diet, make sure that you stay well hydrated, make sure that you exercise every day, decrease your stress, decrease your anxiety, and do everything you possibly can to optimize your health, including taking your medications.
I really like the what you just said about some things that are very dear to me, which is exercising, walking 30 to 45 minutes a day. I think that's very important for the transplant patients because the immune suppressions that we give them actually also induces insulin resistance and metabolic syndrome. And we know that if you exercise on a daily basis, you're going to be healthier and thus less likely to get the infection. The other thing is decreasing the anxiety. And I think, I mean, this is a really crucial piece of advice for the transplant patients. The numbers that we're seeing in the transplant patients up till now are not too high. So really just decreasing the anxiety may help you in paying attention to the things you actually need to do, which is cleaning the surfaces, isolating yourself from everybody, and not taking in all the fear that is perpetuated. I think that would be very important for our transplant patients.
Right, thank you.
Thank you so much, Jason. This is an excellent presentation. I'm sure that our patients and our staff have benefited greatly for you. One more question before you go, maybe, because it says I have a heart transplant. Does that make me a super high risk, giving the increased risk in cardiac patients in general?
So we don't have a lot of data on COVID-19 on heart transplant patients. So what I'm going to talk about at this point is going to be more kind of common sense, but we don't have randomized controlled trials or good data even in healthy patients. But at this point, if you are a heart transplant person, we are seeing significant cardiac effects on a number of patients from COVID-19. I have personally taken care of patients that have had heart attacks at age 36, age 42. People are having elevated troponins very early on, much sooner than we normally would see with people with heart disease. You can develop myocarditis and heart failure from COVID-19. We've had a number of different very good discussions with all of our cardiology groups throughout the system on how to optimize cardiac care for patients with COVID-19. So we have a good plan in place, and as more data becomes available, we will absolutely share it with our heart transplant patients.
Well, thank you so much. And I think this is a big discussion. We actually had another question about myocarditis, not in the transplant patient, but in general. So I think you've answered that. The risks reported from China were were sort of high for the myocarditis. Luckily, I don't think we're seeing that yet here. So we appreciate maybe in our next session that you would come up to us with some follow-up. So thank you very much.
Thank you.
I would like now to proceed with our next speaker. This is Dr. Hassan Ibrahim. Dr. Ibrahim is a professor of medicine, and he is the Charles and Ann Duncan Centennial Chair in Nephrology. He's the head of nephrology and the director of the Living Donor Transplant Program at Houston Methodist. And what we've asked him to talk about today is the contribution of comorbidities. We know that the transplant patients, whether after transplant or on the transplant waiting list, have a lot of associated comorbidities related to high blood pressure and diabetes. And Dr. Ibrahim has done a really comprehensive search about hypertension and COVID. And I thought he would be very useful if he would present that to us. Hassan, thank you very much for coming.
Thank you, Dr. Gaber. I would like to start this discussion by setting the stage why the issue of hypertension and diabetes has come to people's attention. There has been one report which demonstrated worse outcomes in COVID-19 infected hypertensive patients who were receiving a specific type of antihypertensives called ACE inhibitors. This data collectively, however, comes from 32 COVID-infected patients who did not survive the ICU stay. So it's very small numbers. Importantly, 20% of these patients had cardiovascular disease or diabetes. So how much of these conditions contributed to the outcome versus the medication is unclear. Again, obviously, this is a small series of patients, and we need to be careful on how to interpret this information. And let me take you through what the main issues are. Is it true that people with hypertension more likely to get COVID infection? If one is hypertensive and is taking this specific class of medications called ACE inhibitors, and these are medications that generally end with pril, like lisinopril, captopril, enalapril. Are these hypertensive individuals have higher risk of infection? And a different class of medications called angiotensin II blockers, and those are ones that usually end with TAN, such as losartan, valsartan, irbesartan. Is it possible they're actually helpful in combating COVID-19 infection? Well, this is what we know. There has been 4 major landmark papers published in the New England Journal of Medicine, Lancet, JAMA, and the largest trial or the largest observation of 1,000 patients who are infected with COVID-19 demonstrated that 15% of these individuals had hypertension, and it was noted that those with hypertension ended up having severe disease. The 3 other studies collectively has less than 400 patients in them. Now, how does one interpret this information? 2 things. One, it is very clear that the chances of one being hypertensive in these infected individuals is actually not higher than the prevalence of hypertension in the general population. The most important issue here is that none of this information accounts for other conditions such as age, for example. As we get older, we're more likely to be hypertensive. So how do you separate the effect of older age from the fact that someone is taking antihypertensive is really a main issue. So I think the general message, while these studies demonstrate higher risk in hypertensive patients, I think the conclusion is not very strong, as there has been no accounting of other comorbid conditions. Now, diabetes and hypertension are commonly treated with medications called ACE inhibitors or angiotensin receptor blockers. The concern about these medications, or the possible concerns, is that the angiotensin converting enzyme 2 receptor is the target of COVID-19 infections. And the concern is whether these antihypertensive medications can raise the angiotensin converting enzyme 2 receptors and therefore increasing infection risk. Well, let me show you what we know so far. These are important things to remember. ACE inhibitors bind to the angiotensin converting enzyme 1 and not angiotensin converting enzyme 2 receptor. And again, remember the ACE2 is the one that actually binds to the COVID virus. Angiotensin receptor blockers bind to a receptor type 1. Now, ACE2 is actually a very helpful thing in a physiological state. And what it does, it actually shuts off angiotensin 2 production and turns it into an inactive form. And this inactive form is less likely to lead to high blood pressure and fibrosis. So what is the evidence that these medications increase angiotensin converting enzyme 2 levels? We have looked at what's published in the animals, and what we find is that some studies show that ACE inhibitors actually increase ACE2 level, but other studies have not. So in animals, one cannot be certain that this is true. Now, what's more relevant is the data in human. And to date, there has not been a single study that showed that ACE inhibitors actually increase the angiotensin 2 receptor level. So I think this is quite reassuring. So the big picture is the following. The coronavirus to enter the cell, it needs the angiotensin 2 receptor, and it also has to be very close to the angiotensin 2-1 receptor. What happens if one were to think about using an angiotensin 2 blocker, this would disrupt or dissociate the angiotensin 2 receptor from the A2 blocker and will possibly allow less entry into the cells and less infection. So ACE2 is needed for the virus. There is animal data to suggest maybe angiotensin 2 receptor blockers, but not ACE inhibitors, may allow less virus to get access into the cells. So considering what I've just showed you, professional societies have actually made an official position. And at this time, there is insufficient evidence linking these antihypertensive medications to the infection risk or the infection outcome. Certainly the numbers are too small, and the methods described in reaching these conclusions is quite limited, as it has not accounted for other conditions. We believe strongly that patients should remain on these agents till there is better evidence to guide us. Now, one practical issue, since angiotensin receptor blocker could potentially lessen entry into the cell, could someone be changed from an ACE inhibitor to an ARB till we sort this out? I think this issue is yet to be resolved, and I think people should be aware that most angiotensin receptor blockers have some recall issues, so I think that's an impediment to recommending such approach. Now, what are we doing to understand this? There's 2 University of Minnesota-based trials. These are multi-center trials. We'll have hundreds of patients, and they will randomize patients to losartan versus placebo. Again, this is an angiotensin receptor blocker, and it will test whether this drug actually prevents infection, and in those with infection, to see if it actually lessens the extent and the severity of infections. We expect the results of these trials to be available in April of 2021, unfortunately, so it'll be a while. Now, in an attempt to kind of look at this, I think what we're currently proposing to do here till the data from the randomized studies become available is to actually do a simple study by taking 600 patients who are hypertensive and 200 of them on A2 blockers, 200 on ACE inhibitors, and 200 who are taking other antihypertensive medications. And once the test becomes available to actually see what is the seroprevalence, or what is the prevalence of infection according to treatment group, and I think if we see a signal that there's a difference between these groups, I think it will be very important to know. So I think at this time, I think patients should remain on the blood pressure medications they are on. I think the data is insufficient to make any changes, and hopefully we'll have answers in the near future. And thank you.
Well, thank you so much, Hassan. I think this is a very important topic for our patients, because clearly the majority of our patients are taking blood pressure medications in all sorts of organ transplants, not just the kidneys, but the hearts, the lungs, the liver transplant patients. And the fact that we don't have any evidence yet that they should switch or change their blood pressure medication is very important for them. While you were speaking, we got a couple of questions that I would like for you to attempt to answer, and then I will ask you specifically about your presentation. The question is, I don't know, it's a hard question, but how would COVID-19 infections affect outcome in transplant patients? Do you think that we're going to see a substantial difference in the outcome?
Well, certainly transplant recipients are generally at higher risk of infections, including the common flu, including bacterial infection, urine tract infections. So I think statistically they're at higher risk. Certainly what we know now, I don't think there's compelling evidence that they behave differently than someone who has other chronic conditions. So I think for the majority of our transplant recipients who've been on a stable immunosuppressive regimen, as long as they practice the CDC outcomes, I think my sense the risk of infection is not higher than others, but we do not know that for a fact at this time.
Excellent. And I think the next question would be, Dr. Knight answered that when he was here a little bit about should we do anything extra in terms of prophylaxis, and I will pose the same question to you. Do you think there is extra steps that our patients need to take?
Yeah, again, according to national guidelines, and you have to remember national guidelines apply to the general population, and there's no transplant-specific recommendations. I think we're extrapolating the general population, and we tend to be more strict with transplant recipients. I do think my advice to transplant patients, we've always built this great relationships where every transplant recipient has a coordinator they can reach anytime. I think you need to use your contact at the transplant center, convey your concerns, and any symptom that is unusual, no matter how trivial it is, pick up the phone and call us. Because as we learn more about this disease, the one thing transplant recipients might be experiencing might be a new way the disease presents, and we need to stay in constant contact with them.
Well, that's a very important observation, of course, because the disease is still evolving, and you're right, the presentation may be different, and our patients have to be aware of the fact that we are open for business. We are now 100% in telemedicine. They can reach us 24/7, and we'll have people to answer questions for them because we don't want them to feel alone. And it's not only the patients who've had a transplant. We have almost 2,000 patients on the transplant waiting list, and these patients have also access to us to answer their questions and take care of them. Dr. Richard Knight is going to talk about immune suppression, but maybe you can answer one of these questions, which is, how would you suggest managing immune suppression in the transplant patients? How is that sort of conceptually something that we can do, and how would we do it?
I think the general guidelines we follow in the setting of any severe infection in transplant should apply. I think all of us will think immediately about opportunities to reduce the amount of immunosuppression in the setting of active infection. A typical transplant patient is on steroids, tacrolimus, and CellCept. Certainly, taking people off steroids abruptly is not a good practice because they're heavily dependent on it. So I think the questions that remain, which one do you take people off if you were to do that? Is it tacrolimus? Is it CellCept? And there really is no data to guide us. I think the only data that's available is an older paper on Prograf actually might conceivably modulate the viral impact on cells.
Yeah, that's what Richard is going to
It might actually be the drug to keep people on and maybe take off the anti-metabolite. But as you know, the experience is limited. But I think the key is minimizing immunosuppression as much as you're able. And I think for our sister hospitals in the system, if you have a transplant recipients, please reach out for us so we could handle and help you aid in management of immunosuppression.
Perfect. Thank you so much, Dr. Ibrahim.
Thank you.
Very helpful for our patients and our wait list patients. And now I want to remind everybody that you can text questions to us to DeBakey 37607, or you can write questions online to Paul Everywhere, POLLEV.com/DeBakey. And now I would like to introduce my next speaker. That's Dr. Howard Huang. Howard is the medical director of the lung transplant program here at Houston Methodist, and a well-known translational researcher who's been very interested, of course, because of his vantage point on the front line with the lung transplant patients about the whole disease sort of progression, the pathophysiology, the stages of it, and also the advanced therapies that we are working on for COVID-19 in the transplant population. I think, Howard, you can put your slides on. Then we can get you started. So, Howard, I know you've spent quite a bit of time, and you've been one of the sort of my major resources in terms of questions that it comes about the virus because of your very intimate involvement with how COVID-19 is affecting our patients. So, I'd like to get you to make I'd like you to get to make your some remarks about the progression of the disease and what's the pathophysiology and how the intervention is going to be. And then I know you've been part of the group. You've been part of, sorry, I'm looking the wrong way. You've been part of the group. You've been part of the group that's working on the novel therapies that are being administered at the institution for the virus. And so I want you to also give us a little topic or presentation about that. I think once we have all of that, we can answer that question that I think everybody is asking about how does immune suppression modify the course of disease, but that'll come after we discuss the regular sort of course of the disease. Howard?
Okay, we're having a little trouble finding the slides, but while we work on that issue. So one of the things I wanted to discuss was the kind of this conceptual framework that's developed around COVID-19 disease. And that covers not only immunosuppressed patients or transplant patients.
Can we hold on for a second? Yes. We're trying to find the correct mic for Dr. Huang so you can hear him. Can we go? Excellent. So Howard, let's start again.
Okay. So one of the things I wanted to cover in my segment is the kind of conceptual framework around how we think about disease in patients infected with SARS-CoV-2 that then go on to develop COVID-19. And this includes patients who are immunosuppressed and non-immunosuppressed. There seems to be kind of two major kind of clinical phases. So the first phase is really where the infection is taking hold and there's a viral replication going on. And there is a race between the infected person's immune system in containing the viral infection and then the virus trying to expand its numbers within the infected host. And the second phase really involves kind of this hyper-inflammatory state. And that doesn't occur in everybody. So, as Dr. Knight previously mentioned, most patients develop perhaps cold symptoms. There's some evidence that maybe up to 25% of patients are completely asymptomatic. And I think from a community disease transmission standpoint, that's very important because those are people who are inadvertently spreading disease. But then there is the minority of people who then develop severe disease. And these are the people that become ill. They develop respiratory symptoms. Some of them develop hypoxemia or low oxygen levels. And then a subset of those people go on to develop very severe disease and require critical care. And some of these people are on very high levels of oxygen. This could develop very precipitously, meaning somebody is on room air and all of a sudden having this explosive progression in disease and ending up in the intensive care unit and frequently requiring urgent intubation and mechanical ventilatory support.
So if one takes what you're saying and puts it in stages, you have the first stage of viral replication, the second stage of inflammation or response to the virus that's mediated by the body, and then if that goes haywire, then you get the lung failure that's related or is an after effect of the inflammatory response, and then that generates its own set of inflammatory responses, right?
Yes, I think that's a good way to summarize it. A big part of this is collateral damage that's caused by the infected host's own immune response. And so if you have this over exuberant response to the viral infection, it causes severe injury not only within the lungs, but we're seeing the myocarditis, we see cases of renal failure, we see shock, kind of this complete dysregulation of the inflammatory response. That's a runaway response. And we see that in severe infections caused by other organisms, so septic shock. If you had a bacterial infection, for example, can manifest similarly, where this kind of immune response becomes a detriment instead of something that protects the host.
So the question then is, in these cases, finding the proper time to do the proper intervention becomes really crucial, right?
Yes, absolutely. And I think that's really the dilemma here is that where do we start deploying the anti-inflammatory response? Because the inflammatory response is important in containing the virus. But if it doesn't resolve, then it becomes destructive. And when do we shift from therapies and strategies to contain virus replication into more of an anti-inflammatory strategy? Because I think if you were to inhibit the inflammatory response too early, that could be counterproductive.
So I know you spend a lot of time thinking about that. So where do you think we need, I know that in the first phase we're giving those antiviral things that prevent the viral replications, right? The remdesivir and other drugs that are antiviral, just like we would do with any other infection that we have, like a CMV, for example, we give antiviral medications. How do we know that the patient has progressed enough to where we have to start thinking of anti-inflammatories?
So there are some of these biomarkers that have been described, and so these are kind of inflammatory markers that have been associated with it. There are also, as Dr. Knight also mentioned, there is this kind of association with leukopenia and kind of hematologic derangements. The people with high mortality seem to be associated with a kind of early and progressive kind of derangements of these inflammatory markers and the hematologic markers. So the inflammatory markers would include things like C-reactive protein. There are kind of indirect inflammatory injury markers such as LDH that are elevated. Some people develop high ferritin levels, very high ferritin levels. There is also association with not only the
the leukopenia, or specifically, it's really lymphopenia. So it's interesting because it's not necessarily a lack of white blood cells. It's really a kind of a relative absence of lymphocytes that play a major role in an adaptive immune response.
So when we talk about inflammatory mediators, we're sort of lumping a whole bunch of things together. What's the best guess now? I know that there is not a lot of data, but what's the best guess now about what are the mediators that we need to think of blocking or changing?
So there's a number of cytokines that are associated with pro-inflammatory states. So one of those molecules that have received a lot of attention is IL-6. So there are actually multiple late phase trials being investigated for COVID-19 involving agents that block the IL-6 receptor. That's one of these kind of common modes of inflammatory response. Other inflammatory cytokines include IL-1, also TNF-alpha. Interestingly, there was a report out in New York, a very small series, about a molecule that inhibits CCR5, which is normally a target for HIV entry into the cells. But by blocking this receptor, there appears to be some kind of positive response from an inflammatory standpoint.
So some of the HIV medications are being used in the antiviral phase, which is the early phase of the treatment. Would that have any extension into the CCR5 blockade, or is that a separate compound or a separate molecule?
I think it's probably a different mechanism, because this is an antibody that specifically blocks CCR5 and also seems to kind of dampen inflammatory responses.
Now, we've been talking for some time about using that antibody for treatment of rejection, because it was it comes back as something that we can use for the COVID patients. It's very interesting.
Right. So I think the immunology is really very intriguing, and there are these common modes that the body responds with the immune system. It's just that very few. Well, this is a novel virus, and so you have this situation where the immune response is responding to something it has not encountered in the past. And on top of that, there's not any sort of population level immunity. But some of these common playbook rules that the immune system follows still apply. And so I think our challenge is to kind of evaluate how that applies specifically to COVID in particular. What's common to other infections that we've actually done a very good job at treating. For example, a lot of the viral infections that we've learned a lot over the past several decades. We've gotten better at developing vaccines. We've really gotten better at antiviral therapy. So I think our challenge is to really rapidly kind of leverage that body of knowledge and hopefully be able to make some advancements.
Well, it just makes great sense. In view of the concept that is on the screen now of your viral response phase, the inflammatory response phase, and how they sort of line up together. The biggest question that people are asking now is, because our patients are in immune suppression already, that could be not very good in the viral response phase, but it's actually very good for prevention of that secondary immune response phase. Can you give us your personal experience and observation to that? Speculate a little bit. I know that there is not a lot of data, but speculate a little bit of how you think that's going to modify our response or what we need to do for the patients.
Yeah, my suspicion is that there may be some organ-specific differences in terms of, because we know that the threshold and kind of the requirements for immunosuppression varies between organs. So that is probably going to have some impact on how likely you are to generate a very, maybe perhaps over-vigorous response to an infection. So I would suspect that the transplant patients are not going to respond exactly the same. And when they present with infection, they're probably also not going to present exactly the same as somebody who hasn't received a solid organ transplant and is not chronically immunosuppressed.
So if you're faced with a patient now, the next question, I'm going to ask that to you, and then again I'm going to ask it to Richard Knight when he speaks. What would you suggest the modification of the immune suppression would be? Can we what's the strategy?
So I think it wouldn't be unreasonable to hold the cell cycle inhibitor up front. The tacrolimus, there have been a few anecdotal reports of where very aggressive reduction in immunosuppression has actually compounded the problem by creating the conditions for developing rejection. So I would be hesitant to completely cut out immunosuppression. So I think a reasonable strategy would be to really either severely reduce or temporarily halt the cell cycle inhibitor, and then kind of let the prograph or the calcineurin inhibitor level come down slightly. But I wouldn't kind of completely cut out on the calcineurin inhibitor. Now the other question would be, what do we do with the steroids? And so I think there's there's some guidance from the WHO about how steroids really are not recommended in COVID. But I think in some patients, and specific, especially in transplant patients, I think completely eliminating all corticosteroids may not be such a good idea. And I'm speaking that from a lung standpoint. I know in other solid organs there have been successful demonstrations of steroid-free immunosuppression regimens. But I wouldn't consider steroids just completely off limits. I think you have to take that into the context of how far out you are from transplant, what your risk is for rejection, and what sort of organ you've transplanted.
So in the patients we've had the 3 patients that I talked about. One of them is one of your patients, but in the 2 kidney patients that we've had, they've been far enough away from the transplant, and the course was not very complex, because we have a question here that says, are you seeing it taking longer to recover, or is the recovery sort of follows the pattern of the other patients? And luckily, from my perspective, the kidney patients didn't have severe enough disease, so I thought that the course to recovery was actually the same that you would see in another person that just gets a symptomatic infection and recovers. What are your observations in the lung patient?
So we have limited observations, but the one severe case we had actually presented very atypically. So he did have some within about 3 or 4 days after exposure became symptomatic. However, he did not have any shortness of breath, was not coughing at all, and really did not have any evidence of a lower respiratory tract infection when he presented. He presented with some myalgias. He was fatigued. He had fevers, and it was unclear where the fevers are coming from. And then he had kind of pretty focal infiltrate, kind of very located in one lobe, but nothing like the ground glass that's typically described. That's multifocal in a lot of the COVID cases that have been presented. But within about 4 or 5 days of presentation, it went from not requiring any oxygen, not being short of breath, not even having a cough, to ARDS. And so it could progress very explosively. And so this is, we've had limited experience, obviously, but that's also been described in other patients who decompensate.
And do we have an idea about the length of each phase? I mean, is it like 3 days in phase 1? And because that would determine what do we do with the immune suppression, right? Because usually with other infections, we cut immune suppression down and leave it until the patient is ready to recover. That's what we do with CMV, for example, right?
Right.
And then if we don't bring it up, then you get an inflammatory response that leads to rejection. Are these phases, can we determine how long they are? Can we take a guess?
I think we need more information, first of all. It's kind of guessing. We would suspect if you look at kind of the time from symptom or from infection to becoming symptomatic being 4 or 5 days. And then becoming really significantly ill within 7 days. I think that kind of initial time window would be where you would deploy, ideally, your antiviral therapies. However, and then that's probably the time you also want to start really initially dropping your immunosuppression. As far as when to reinstitute that or kind of prevent the emergence of this hyperinflammatory or cytokine release syndrome, I would say maybe 2 weeks down the road, or something to that effect. But it really depends on the clinical trajectory that the patient is following.
So hypoxemia is a pretty important.
Right. So if you look at the diagram here, and this is kind of a concept that was brought up by a couple physicians from Brigham. They they posit that stage 2 is really where you transition from kind of mild symptoms to then developing lower respiratory tract symptoms and hypoxemia. And so 2B, kind of in the middle there, is really when that host response really starts to take hold. And so that's, kind of seems the crucial transition point, but really kind of timing that, we need more observations. We need to get better in a hurry to, in terms of, how we go from an antiviral strategy to an anti-inflammatory strategy.
So actually, we just attended a international conference call this morning. There are attempts to create, in association with the NIH, a worldwide registry for all transplant patients that had COVID infections. And actually, they're going to start taking cases in maybe in the next 3 or 4 days. So maybe the data is coming, and I really thank you for bringing that up. You've answered one of the important questions that keeps coming up, which is, do we expect the response of the transplant patients to be different? Have we started anybody on Kaletra, or is that's not part of what we are planning to do?
We haven't, just mainly because of its potent interaction with the calcineurin inhibitor. It's not to say that it's off limits. And I think, the New England Journal article that came out about a week ago that showed that it was not effective in a phase 3 trial, people have to also consider what context that was performed in. So one, the most important thing is that they treated a population of very severely ill patients. So does the antiviral work? Well, if you look at some of the subgroup analyses, it seems like the patients that they treated early on had some benefit. That wasn't statistically significant. However, I think if you were to look at it earlier in that kind of infection time frame, you might actually see some benefit. So I think there's some effect. So if we're going to use Kaletra, there's going to be more of a drug interaction. I think that's where people are also starting to study the effect of hydroxychloroquine. So that's gotten a lot of press. I think there's going to be quality data that's going to come out relatively soon from Europe, and to see if it really does help with viral clearance. Anecdotally, I've seen it help in some patients, but that right now we just don't have kind of really solid data to base that guidance on. But I think the remdesivir definitely is a promising agent, in terms of the antiviral strategy.
Yeah, and I think our study here, it's very hard to tell yet, but we seem to be thinking, at least collectively together, that there may be some response to it. So I want to take you to this question. I mean, it seems a little bit a light question, but it's a real concern for a lot of our patients. About the dogs and the cats, I think they took that off. Yeah, so should I be concerned? Should transplant patients be concerned about their dogs and their cats? Would they be able to transmit the disease to them?
There's been some reports out in the media of that potentially, and of samples being taken from pets that are testing positive. So is it possible? I think you would consider your pet. Is there a possibility of fomite transmission? I think there is. For a pathogen that's transmitted by droplets. And so if it can be transmitted by, clothes or, kind of contact surfaces, I don't see why it couldn't be transmitted by pets.
So you could walk him but not hug him, basically. I mean, I don't know how to advise people. I mean, we know that this is a risk, but it's a very small risk. And I'm not sure because
I guess you could it's fine if the pet is with you, but it's probably a risk if they're interacting with a lot of other people. Yeah.
So try to restrict basically the pet going to other people and just make social distancing for the pet just like you're doing for yourself.
Right. I think taking them to the dog park is probably not a great idea right now. Yeah.
Very good. Very good. Okay. Well, thank you so much, Howard. Very enlightening. We have one more speaker, Dr. Richard Knight, who is making his way here to talk to you about the immune suppression in the transplant patients. And I want to remind you to text your questions to DeBakey 37607 or online to pauleverywhere.com @DeBakey. You do? Okay. And while Richard is making his way, maybe you can give us the extra couple of slides that you have?
Okay, so I think this just kind of illustrates how many unknowns there are out right now. It's a very rapidly evolving situation, and so there's a lot of questions that we need to answer quickly. But first and foremost, how much of the disease is out there? How many people are becoming infected? Are there transplant patients that are becoming infected that are completely asymptomatic? I would suspect yes, but we don't have that information right now. Other things are, like as we've discussed, is the disease course similar or different from patients who are not transplanted? Are there other issues that impact transplant? Are there specific differences between organs? How does HLA impact the disease course? What about immunosuppression management that we talked about? Role of immunomodulatory therapies. How does that impact kind of the immediate response to the disease, but also the long-term effects on the allograft or the transplanted organ? Does that cost? Are we going to be dealing with rejection down the road in these people who are infected? And is there increased susceptibility to secondary infections once you become infected by COVID? What about protective immunity? How does that develop in these people, or does it develop in these people once they become infected? And once, hopefully, we have a vaccine, how do people respond to vaccines? So I think there's a lot of unanswered questions, and I think we need really much more investigation. And then the last thing I want to mention was this is actually a recent publication from Nature Medicine, where they really studied in great detail a woman who had been infected with COVID-19 and returned to Australia, became symptomatic, and they followed her on multiple dimensions, looked at how her immune system responded to the disease. Now, this is somebody who developed moderate disease, had some infiltrates, were symptomatic for a while, but was never hospitalized or critically ill. But this is a sample of one. But this is the level of information and analysis I think we need on multiple transplant patients with multiple different transplants, different sorts of transplants to really answer a lot of these questions.
Thank you so much, Howard. Very illuminating, and I'm sure that you're planning quite a bit of studies in all of these areas. I heard you talk to some of our HLA colleagues about doing that. I know you're on the group that's looking at all of the new investigational trials, so I'm hoping that we will come out of this with a wealth of knowledge about these patients. Our next speaker is Dr. Richard Knight. Dr. Knight is a professor of surgery, and he's the director of kidney pancreas transplantation here at Houston Methodist, and a clinical researcher and somebody that really has managed throughout his career to produce quite a bit of research information that is useful for our patients and their clinical care. And I'm happy to have him here to talk to us about immune suppression in the transplant patient. Welcome, Richard.
Thank you very much. So what I hope to do is speak to you a little bit about management of immunosuppression in the transplant patient with COVID-19 infection. As you've heard from all of the speakers, it is an emerging problem. There's relatively little data to call on, but I'll take you through what we know so far and give you the kind of recommendations that I think that we can advise. So to begin with, I think it's important just to review the immune response the host, the recipient, directs towards a transplant. One way of looking at it would be to think of the immune response as two arcs, that of the antibody-mediated rejection, and the second is T-cell-mediated rejection, and how we prevent it and how we can treat it. In terms of antibody-mediated rejection, we actually have no drugs to prevent that form of rejection. We avoid it by doing a cross-match before transplantation, which is critical for heart, lung, kidney, and pancreas transplant, not so much for liver transplant. But in the setting of a negative cross-match, the likelihood of developing an antibody-mediated rejection is quite low. If that were to occur, we do have treatment modalities for it, as shown here. IVIG, plasmapheresis, rituximab are all agents that are relatively effective at reversing antibody-mediated rejection. Thankfully, the incidence of that form of rejection is quite low. And in actual fact, for most transplant patients, the focus is to prevent T-cell mediated acute rejection. And the way we do that, for the most part, is through the use of maintenance immunosuppressive agents, the ones shown here. The standard regimen in the US is the use of tacrolimus, mycophenolate mofetil, and prednisone, although there are other alternatives. When I began in this field in kidney transplant, the incidence of a T-cell mediated rejection in the early post-transplant period was about 50%. With evolution of drugs that we use today, the rejection rate is about 10%. So these drugs have been incredibly effective at preventing T-cell mediated rejection. If we were to have rejection, we do have treatment, as shown here. The use of steroids, antithymocyte globulin are really important in that regard. Now, as I say, the 3 drugs we use are shown here. We use a combination of drugs because they're all designed to inhibit lymphocytes, T cells in particular, from replicating. And they act at different points in the cell cycle to affect that response. Tacrolimus is what's referred to as a calcineurin inhibitor. The way that drug works is to prevent the lymphocyte from becoming stimulated. It actually prevents it from replicating its DNA early after recognition of foreign antigen. Mycophenolate mofetil works in a completely different way. Again, it prevents DNA replication of rapidly dividing cells. And prednisone works in a multiplicity of ways, both inhibiting recognition of foreign antigen and prevention of upregulation of lymphocytes. So by using 3 different drugs that work in different ways at different parts of the cell cycle, we can effectively prevent rejection. Now, it's fair to say that T cells, from an evolutionary standpoint, were not developed to prevent to induce rejection. They are there to prevent us from becoming infected. And what's particularly awkward is that T cells are particularly useful to attack viruses. So necessarily, when you use immunosuppression, you're inhibiting that particular part of your immune system that is critical to protect you against viruses. So necessarily, transplant patients are at greater risk of viral infections. And that can be manifest in 2 different ways. There are a series of what we call opportunistic infections to which transplant patients are at risk. Opportunistic infections are those that really only immunosuppressed patients are really at risk. In this list, with the exception of varicella zoster, which causes shingles, most non-immunosuppressed patients, these infections would be of no consequence. But in transplant patients, CMV, BK, EBV, herpes simplex, and parvovirus can all cause serious disease, and in some cases can be potentially fatal infections. And this is a result of taking immunosuppression. Similarly, there are other viral infections that occur in the community to which non-immunosuppressed patients can suffer. Shown here, there are the respiratory viruses, adenovirus, rhinovirus, and seasonal influenza, which we can all get sick from, but typically it will not result in a hospitalization. Similarly, RSV, or respiratory syncytial virus, is not a respiratory virus that most non-immunosuppressed patients should worry about. But in a transplant patient, although they're not more likely to develop these infections, they are certainly more likely to get sick from them. And then the other one is the norovirus. This is the common GI virus. Again, most non-immunosuppressed patients can get sick from this, but generally it can be managed at home. Whereas in a transplant patient, because of the use of immunosuppression, they're more likely to get seriously ill and thus require admission to the hospital. So how do we manage a transplant patient with a virus infection? It's fairly straightforward. Unfortunately, we don't have a lot of agents that are terribly effective at treating these viruses, with the exception of acyclovir and ganciclovir. So the way we typically manage it is in someone with mild to moderate infection, we may withdraw the mycophenolate, we may reduce the dose of tacrolimus. And then in a patient with moderate to severe viral infection, we're more likely to completely withdraw the mycophenolate and the tacrolimus and just continue prednisone until the patient recovers, and then we gradually reintroduce these drugs. And of course, the goal of this is to allow the T-cell immune response to act in its appropriate way to take care of the virus. So I've made this fairly simple, but actually there are some confusions here, and I want to address those. This is a report from a paper that Dr. Huang sent me, which I thought was very interesting. This was a laboratory study where they were looking at replication of coronaviruses, obviously of which COVID-19 is one. And what they're able to show was that surprisingly, tacrolimus was actually quite effective at inhibiting the replication of the coronaviruses. And the way this study was done is that the virus was put in a test tube, and at the beginning of the experiment, they added tacrolimus at higher and higher doses, and they were able to show that the immunosuppressive agent actually inhibited replication of the virus. That's a little bit confusing, but there is an explanation for that. The way tacrolimus works is that once it enters the cell, it binds to a protein in the cytoplasm called, not surprisingly, FK binding protein. And this is one of the proteins that it is likely that the coronavirus needs in order to replicate. So interestingly enough, use of tacrolimus may actually, in fact, inhibit replication of the virus. I think what's critically important in this experiment was that they added the tacrolimus at the beginning of the experiment. They didn't allow the virus to begin replicating and then add the tacrolimus later, which in my opinion probably wouldn't be so effective. So I don't think this is really just a one-off experiment, because I went in and looked at the literature, and there are some human studies that support the idea that immunosuppressive drugs may actually inhibit viruses. And this comes from a study that we did here in our kidney and pancreas patients. In kidney and pancreas world, we see more issues with acute rejection. So in fact, we use higher doses of immunosuppressive agents in that group of patients. And not surprisingly, we see more virus infections. And the two that we worry most about are CMV and BK. So in this report, what we showed was that when we transitioned to a new immunosuppressive protocol, one in which we took our patients off CellCept at 1 month and added an mTOR inhibitor, in this case either sirolimus or everolimus, we found that that drug seemed to be protective, that carried out to 2 years, as you show here on these slides on the left and the right. The graphs show that the incidence of BK and CMV infection was in fact much lower in the mTOR treated group than the CellCept treated group, suggesting that in some way mTOR may be inhibitory of viral infection. Well, this isn't a one-off study. There was another study which, interestingly enough, we also participated in. This was a much bigger study done in kidney transplant patients. It was what's called a phase 3 study, involved many centers around the country, in fact around the world. They enrolled over 2,000 patients and treated the patients in a similar fashion, that half the patients took standard dose tacrolimus in combination with CellCept and prednisone, whereas the second group received everolimus, which is an mTOR inhibitor, in addition to reduced dose cyclosporin or tacrolimus in combination with prednisone. And the important outcomes, acute rejection, graft survival, and renal function, were equivalent at 24 months. But what was really interesting was that, again, in the mTOR-treated group, that group that received either everolimus had a much lower incidence of CMV or BK virus infection. And again, the likely explanation for this is that the way everolimus or sirolimus works is that it binds to a different molecule in the cytoplasm, something it binds to, again, not surprisingly, it's called an mTOR binding protein, which is chemically a phosphokinase. And it seems that by inhibiting that molecule, the drug prevents the virus from replicating. And one way I think we can explain this is to recognize how viruses work. A virus enters the host cell not to destroy the cell, but to use its machinery to replicate and then leave the cell. One metaphor you could think of it, if you think of your house as the cell and the virus as as someone breaking into your house, the virus isn't trying to destroy your house. The virus just wants to get into your kitchen to make dinner. So if you can disrupt that, you can pull the plug on your refrigerator, pull the plug on your stove, as these immunosuppressive agents may be doing, you can inhibit the replication of virus. Now, I'll point out that this idea is somewhat speculative, but this may turn out to show that these drugs may actually lower the risk of coronavirus infections. I want to just, to finish up here, take you through a few studies from the hotspots in the world and present their opinions on coronavirus infections in transplant patients. This paper just came out in Liver Transplantation Journal. It came from a group in the Lombardy region of Spain, which is, the Lombardy region of northern Italy, which is one of the hot spots for COVID-19 infection. The author of this report states that they are one of the largest pediatric liver transplant programs in Europe. He pointed out that there's about 1,000 new cases of COVID infection in his area. But interestingly enough, they have seen no COVID infections in their transplant recipients. And he goes on to try and explain why this may be and takes us through the other coronavirus infections that we've seen over the last few years. There is the SARS infection, which originated in China, the MERS infection, which originated in the Middle East, and then the COVID infection, which originated again in China. And these are all zoonotic infections, is to say that these are infections that originated in other animal species. Regarding the SARS infection, which had lasted from 2002 to 2003, this presented as an atypical pneumonia. There were actually only 8,000 infections in the entire world, but it had a much higher case fatality rate, close to 10%, which is about 10 times higher than what we're seeing with COVID-19. But similar to COVID-19, risk factors were advanced age, male sex, and other comorbidities. Interestingly enough, immunosuppression was not one of the risk factors, and in fact this author states that there have been no reported transplant deaths due to this infection. It may be, of course, that because the prevalence of the infection was so low that there were no transplant deaths for that reason. MERS is, as I said, another zoonotic infection that appeared in 2012 and still exists. This fortunately has been less prevalent. There's been only about 2,000 infections, but the fatality rate is much higher. Approximately a third of individuals who contract this infection go on to die. And again, risk factors were advanced age, male sex, and comorbidities. Again, immunosuppression was not a risk factor, and in fact there would be no reported transplant deaths. So what I'm trying to suggest here is that there is some, albeit I will point out speculative opinion that immunosuppression may potentially be protective, but we don't know at this time. I finally want to talk about 4 case reports. These are the only reported cases in the literature at this time describing outcomes with COVID-19 infection. The first one comes from China, not surprisingly, from Wuhan, China. 52-year-old male with a kidney transplant on tacrolimus celseptin prednisone who came in with a COVID-19 pneumonia. The approach was to completely discontinue both tacrolimus and MMF and treat with antibiotics, one of which we're probably not familiar, ufenavir. This is an antiviral agent only available in China and Russia. The patient recovered, and with recovery, his immunosuppressive agents were restarted, and the patient was discharged and did fine. The second case comes from another hot spot, this one in Barcelona. 50-year-old male with a renal transplant, actually his 3rd renal transplant, who also had had a splenectomy, making him even more immunosuppressed. He presented with COVID-19 pneumonia. The approach at that center, again, is to withdraw immunosuppression. In the case of that patient, it was tacrolimus and sirolimus. And at last publication, the patient remained critically ill with no follow-up as to how that patient has done. And there have been 2 other reports, again from Wuhan, China, on heart transplant patients. And again, a similar approach. The patients were, the first one, the patient was admitted with a COVID-19 pneumonia. Immunosuppression was discontinued as the patient got sicker. The patient didn't require intubation, and as the patient recovered, the immunosuppression was reintroduced. In the second case, there was actually no discussion of the immunosuppression. The patient, again, did not require intubation, but did get better and is discharged. So in conclusion, obviously we're only a few weeks into this problem in the US. There's very limited data on how we should manage immunosuppression. I think the safest thing to do is to do as we do with other moderate to severe viral infections. Gradually withdraw tacrolimus and MMF. There are good reasons to continue corticosteroids. They do provide some degree of immunosuppression and may also inhibit the cytokine release syndrome associated with this virus. And then, as the patient recovers, reintroduce the drugs. Again, our recommendations are based on very limited data, but based on what we hear in the US, this seems to be the approach that most centers are working from, and this is what I would recommend. I thank you.
Thank you, Richard, very much. Very, very informative, and clearly there are lots of places, I think, particularly around New York, where they're seeing actually some immune-suppressed patients coming with the infections now. So we should have some, at least anecdotal reports from them about how to manage it. But it seems like this is what you presented is sort of the logical approach, and that's what we followed up in the patients that we've had. I got a couple of questions that came through that I'd like to ask you, and I know that maybe we don't have the answers for all of them, but is there any evidence that you can get reinfected with the COVID-19 virus? Is that?
I'm unaware of that. The hope is obviously that you will develop immunity once you've recovered. And you might speak more about the study that's going on here, looking at using convalescent serum.
Right.
But to my knowledge, I am unaware of patients becoming reinfected.
So what we've seen is some of the patients, I don't think it's reinfection, but they have sort of a second phase for the inflammatory response. They recover, seem to gonna be doing well, and then suddenly again there is a resurgence of the inflammatory response, and they get sick again. I don't think that's a reinfection. That's
No.
the same course, right?
And that
And I think
typically,
that's- yeah,
that
go ahead.
typically occurs in the same hospital stay.
Exactly, exactly. And I think that that's correct. I think we've had at the Houston Methodist one of the first national studies to look at convalescent serum. And actually people who've had the infection, cleared it up, are now coming in to donate their serum. They're getting plasmapheresed, and that serum is being taken and is going to be like hyperimmune IVIG like we give for CMV to try to rescue patients that are desperately ill. I don't know that we've infused any yet. I know that we've taken the blood from a couple of donors, but in our next session, maybe we can bring Dr. Salazar, who's been leading that effort, to talk to us about that. The second question, and it's not the one on the screen, but it was a very interesting question about should the transplant patients be admitted for even milder symptoms than the other patients. And I mean, since it came up on the screen, I've been thinking about it. I don't know what your opinion is, and then maybe I can chime in and say a couple of things about what I think.
Well, it's a good question. My thought would be to stay at home, to limit your exposure as much as possible. Certainly, we're seeing a lot of people with respiratory infections who, as it turns out, don't have COVID-19.
Right, that's...
So I think we have to be very careful about that. We're trying very hard at this institution to limit the number of people in the hospital. So I think it's fair to say that through working with your coordinators, as long as we can keep in touch with you and you're otherwise doing well, my view at this time would be to stay at home until you need inpatient care.
So I think that, I mean, that's how I would think about it. In my mind, when the question got asked, the most predominant symptom for the viral infection is fever. And we have standard ways of, if your fever is greater than 100.5, you get admitted to the hospital regardless of the cause, right? And I think if we keep that protocol, right, then we're going to catch all of the people that are or are not going to decompensate. So to us in the transplant world is different than in the outside world. In the outside world, we're trying to keep the people out all the time, right? And if you can tolerate the symptom, then stay at home. But if we use our standard transplant admission criteria, people are going to get admitted when they reach the threshold of fever, where we have to do that other differential diagnosis, because clearly in our patients, there are 20 other reasons for them. I mean, the fact that we're having a pandemic doesn't mean that we're seeing people with parainfluenza, we're seeing people that have CMV, we're seeing people that have all sorts of other infections. So coming into the hospital with the standard admission is going to allow us to figure out what's happening with the patients. How should we treat people that are asymptomatic but test positive? So that's a really good thing, because we don't know the length of the shedding, and should we repeat the testing? Should we ask people to wait a certain amount of time? How long are people are shedding? These are questions that, what do you think? I'm not sure we know all the answers.
We don't. I think obviously isolation is the most important thing at that time, so that you don't spread it to anyone else. But we don't really know beyond that the right thing to do.
So what we know in the non-immune suppressed patient is that, at least our general guidelines for the patients, is if you have had the infection, tested positive, feel well from the time your symptoms go away, 5 to 7 days after that, then you can come back to work. Now, we don't know if you're still shedding, but you can come back to work or not, because there are reports of the shedding continuing to like 20 days or something like that.
Sure.
But I don't know if the immune suppressed patients actually shed longer or shorter than other patients.
Yeah, these are all unknowns.
Yes, so I think that the best thing is to be careful, right? Is to err on the side of being conservative, particularly with the immune suppressed patient, rather than trying to expedite their entry into their sort of community, because they may become a risk. I mean, they may survive, but they may become a risk for others because of prolonged shedding or something like that.
Exactly.
I don't know about colchicine. I don't think we can actually answer that question. Do you have
we
any?
don't. I don't think there's enough information at this time to speculate.
Yeah, there's a lot of speculation about all sorts of therapies that can be useful. And we know what we are trying. We're trying the antivirals, We are trying colchicine and, not colchicine, I mean hydroxychloroquine and azithromycin, that we have a trial for that.
Yeah.
We're setting up to try stem cell therapy. We have convalescent serum, and we have a whole slew of new experimental therapies that we're working through the IRB on trying to get them approved, but none of them have actually made it to the patients yet. So that's what we're working on. Again, thank you so much, Richard, and it's been an amazing session in which we talked a lot about the COVID-19 virus and the immune suppressed patients, and I hope that it's been useful for our staff, for our physicians, and for our patients to have this conversation and discussion. And again, thank you very much for the Houston Methodist DeBakey Heart and Vascular Center for allowing us to use their wonderful facilities to create that conference, and hopefully we'll come back to you with more data as we keep accumulating data and have some results from the trials that are ongoing. Thank you very much, and have a great afternoon.